Have we been muted the whole time?
So far.
Oh my gosh. Okay.
Sorry.
All right, let's start
That was
again.
my bad.
Okay, we start again. We've got HMS stain, Crocock methenamine silver, that's the green with the black. You've got black organisms in it, so that makes it fungus. The differential for fungal yeast is histo, crypto, blasto, cocci. Histoplasma, Cryptococcus, Blastomyces, Coccidioides. Which is the differential here. If they were elongated organisms, the differential would be Aspergillus, Mucor, and related things. If you're trying to figure out what the differential of a fungal yeast is, then size is the most important thing, and how the thing buds, that's also important. So the smallest yeast that you could find is histoplasma. So like this size is good for histoplasma yeast. The shape also matters. So if the yeasts are pretty much the same size, like in this case, that is good for histoplasma. All the yeasts are the same size. If the yeasts vary in size, then you have to think Cryptococcus. For Cryptococcus, they will probably also give you a mucicarbon stain, which looks orange. So they will not expect you to figure this out on morphology. So if they want to give you histo, they'll give you a patient is from Ohio, somewhere in the Mississippi River Valley, something easy like that, plus lung nodule. They might give you disseminated histoplasmosis, in which case they'll say patient is immunocompromised. And the yeast will be small and uniform like this on the genes. So remember that for histo. For crypto, they'll give you a mucicarbon stain. The yeast will be different in size, and they will, both histo and crypto, show narrow based budding, meaning that the buds actually where the mother and the daughter connect, that connection point is very narrow. And I'm trying to find one here, something like there, right above the arrow. You see, there's like this and this. So the connection point is narrow. Here's another one. So this and this, the mother and the daughter, the connection point is narrow. If it's broad, there's only one organism. Do you guys know what? Blasto. Easy. Blasto, broad, based, budding. B. It's very easy to remember. Nothing else except blasto gives you broad based budding. For blasto, they give you somewhere in the Midwest, some sort of weird occupation, woodworker or something like that. The stem, they might give you suppurative lesions, they might give you skin lesions. That's very characteristic of blasto. Skin and bone and lung. Mass-like consolidation, that's very characteristic of blasto. And for cocci, they'll give you, the site of where the patient is living. So, Southern California, Arizona, New Mexico, Northern Mexico, those are good areas. So this particular case is a histoplasma nodule. It's a solitary histoplasma nodule called an histoplasmoma. This is the kind of histo that is completely benign. It's like the bugs are already dead and the patient is already cured. So you don't really even need to resect this kind of thing. So they might not give you this, they might give you disseminated histoplasmosis, but the organisms look identical in every setting. So you will get that profile. Clear, everyone? Questions about that? Fungal yeast stuff? Okay. So that's histo. And why is this not progressing? Okay. All right, guys. And I won't give you any stem before you give me a yes here. So there are three pictures: a CT scan, the thing at the bottom, and the thing at the top right. Do you guys know what that is? What is the bottom picture? What stain is that?
It's an H&E.
H&E, standard H&E stain, right? What's the top right then? That's what microbiology sees. So that is actually, you have to go to the microbiology lab to get a picture like that. So that is off of a culture plate. So it's showing something different. So this is what it means when they say mold in the cold. That means in the lab.
Okay.
Mold in the cold, yeast in the beast. So it means in the human. Mold in the cold, yeast in the beast. That is a typical appearance of a dimorphic fungus, of which histoplasma is one of them. That gives you dimorphic fungi. Now, this is the same thing that I showed you on the previous picture, but the stains are different. So this is H&E, and on H&E it looks like this. So there are these cells, these big cells are histiocytes or macrophages. And each big cell like that contains all these little dots. See those? Each little dot is one histoplasma yeast. So it looks different because the stain is different.
This is disseminated.
This is disseminated histoplasmosis. Here you don't have a solitary nodule. Here you have bilateral ground glassoplasties. And here the stem will be something like, transplant recipient, fever, leukocytosis, pancytopenia, elevated transaminases, patient is very sick, febrile. And then if you see the dimorphic thing, so these are actually hyphae. You see that elongated tube-like thing? So the same bug, when you culture it in the lab, it grows hyphae. That's why it's called dimorphic. So the histo is the classic example of a dimorphic yeast. A blasto is also dimorphic. So yeah, disseminated histoplasmosis. Questions? Any questions about, do you guys understand? So the difference between a solitary nodule and disseminated histo, how to tell this is histo. Again, they should give you something in the stem about where the patient lives. I think it won't be fair to know. Good. All right. No stem before you guys volunteer some kind of answer. Stain, anybody wants to say? Agent, very good. Is it the same thing as the last slide? No, okay, good.
It's like a slide. Is it called?
But you're going straight to the answer, right? Give me something before that. Like what's your thought process?
It's like a spherule.
Yeah, round things.
With,
Is that tumor?
it doesn't look like it's.
What does it look like?
It's like a almost like a vacuum.
Yeah,
And inside that, I see rounded structure.
like this, right? This is the vacuole,
Yeah.
and this is the rounded structure.
Yes.
What are you thinking? What might the rounded structure be?
Fungus.
Yeah, but you're jumping ahead. Like you're thinking fungus, right?
Yes, I'm thinking fungus.
Hyphae or yeast?
Yeast.
It's round, right?
Yeah,
Yeah,
it's
yeast.
round yeast.
So you've narrowed it down to 4 things. You're already a winner. You're down to 4. You know this is not histoplasma because it doesn't look like the previous one. So you're
It's
down
not
to 3.
blasto.
You're down to 3. There's no broad-based budding. It's not blasto. You're down to 2 now. It's crypto or cocci. Crypto is small, similar to histo. Cocci is big.
It's cocci.
It's not that big. It is not that. So this is the size of a lymphocyte. See that?
Yeah.
It's about the same size. No, cocci is much bigger.
So this is
Cocci would be the size of this big vacuole.
Okay.
See it? Like really big.
Okay.
And it would be like imagine like a big thing filled in with many smaller things.
Okay.
So kind of like a balloon filled in with smaller balloons, that would be cocci. If you just have a small thing surrounded by a halo, chances are you're dealing with what's left? Crypto.
Okay.
Cryptococcus. So what kind of stem would they give? They would usually give you some kind of immunosuppressed patient. It doesn't have to be in real life, but they'll give you immunosuppressed patient. They might give you CSF, they'll give you meningitis. They might give you mucicarmine stain, which I haven't given you here. But on the mucicarmine, the wall of this thing will stain orange or reddish looking. So remember that if they give you a mucicarmine stain, the only one of these that stains is crypto. So it's absolutely diagnostic for your growth if you see that at orange. They might give you an India ink that's not done on tissue on CSF, but if they give you that, that's what they're looking for. And if they are give you anything about CSF or meninges, this is the only one of the 4 that does that to any significant extent. So they're trying to push you towards crypto if they give you meninges before. Other than that, crypto, there's nothing else I don't think in the stem that would be that helpful.
So what is the vacuole?
The vacuole is a space. Actually, there's some controversy about that. Some people say that it's the capsule. But if that were the capsule, that would stay with mucicarmine, it doesn't. The wall stays. So what I think is that, and what I was taught was that this is actually a retraction artifact. The yeast retracts from the surrounding tissue and gives a space around it. But regardless of what it is, this halo around it is very common in Cryptococcus. So if you see the halo, think crypto. All right? All right, let's go to this. Stain.
GMS.
GMS. All right, guys, you're making progress already.
Thank you.
So because this is a GMS, this must be a fungus. Yeah. So we are already at fungus, and now you are at yeast. Yes. So actually, what's happening here is some of these are cut. Yeah. If you cut it like this, it's long, but if you cut it like that,
So it's hyphae.
it's like
Septated, acute angles.
yes, very good. Where are the septa? Let me see. You're almost a pathologist. Where are the septa? You see that? Yes, that's the wall. Septa. So septa makes it what?
Septated.
Yeah, septa.
Aspergillus.
So for practical purposes, this is Aspergillus. but in real life and in reality, some other things can look like this. So Pseudalisteria, Scedosporium, Fusarium, zebra things can look like this, but in real life, Aspergillus is by far the most common like this. The other hyphae they might give you is Mucor. In Mucor, remember these like how Aspergillus has parallel sides? It's like a tube. Mucor is not like that. It's very irregular and very odd shapes, bizarre looking hyphae. It's hard to tell that they're even hyphae because they're so bizarrely shaped. They are also aseptate or possesses. They have very few septa. If you can easily see septa like that, it's probably a Aspergillus. Fairly straightforward, right? If they give you this, it'll be pretty easy. And in the stem, they could give you anything, The classic stem would be acute myeloid leukemia and neutropenic patients. And then they want you to think like, invasive aspergillosis. Okay? But there are many different types of aspergillosis, so it depends on which kind they want you to make. All right. Stain. HNE. All right. I won't give you a stem till you give me some kind of guess. Lymphocytic infiltration. Okay, I'll give you 65-year-old man. Let's do 42-year-old man with a very low CD4 count with HIV and HIV/AIDS. And I've given you already a why? Why? You just said lymphocytic infiltrate, which you're right actually. So there in the alveolar septa, there are lymphocytes. See those little purple dots? So how does that equate to PJP? What do you expect to see in PJP?
Helmet shaped.
Yes, but you're now talking about the GMS stain where you see the organs of the eye.
What would you see in HIV?
What would you see on HIV? That's my question. Anybody? No, but that's not what the organism. The organism is here. See all this stuff in the alveolar lumen? It's kind of a frothy looking thing, right? It's like that froth is full of organisms. And that froth typically contains these small dots. So just see right above see that little dot? Then see that little dot there? Now I'll remove the thing and see how many little dots are in that thing. It's like a frothy thing with little dots. Each little dot is one organism. That's what Pneumocystis looks like. The alveolar lumens are just flooded with this stuff, and it's all inside the air spaces, we call them the alveolar lumens. And then the interstitial, the alveolar septa is inflamed. So that's what you saw first, the lymphocytes. So that's what you expect to see.
All the pinks.
And the pink stuff is all organism. There are
the dark pink.
like here. This stuff.
All the dark pink like clumps.
Like amyloid type stuff, like the dark.
Like
thing.
here.
In the middle, along with the gunk in the center.
Here, just point to it and I'll tell you what.
Like this or this.
Oh, those are red blood cells.
Oh.
This is a red blood cell. That's a red blood cell. See, the pink of a red blood cell is different than the pink of the Pneumocystis. See, it's a different color. Yeah, so yeah, good that you pointed because I can't even think like you do, I can't even imagine.
At least I learned it now. Like before I go out in the world and embarrass myself.
No, it's like the pathologist asking you, but but what's that thing? You go, no, but the nodule is at the periphery. No, but what's the other thing? And you go, no, that's just that's the patient's defibrillator, It's something like that. It's very hard to think of what artifacts are confusing you. For me, it's very very good question. Please ask All right. So you guys are okay. So the stem for this immunocompromised patient, severe hypoxemia, bilateral ground glass opacities, and they could say a BAL shows you these frothy exudates is a characteristic thing. Then on the GMS, you will see helmet-shaped forms. They look like yeast, actually. They're cysts, but they look very similar to histoplasma, but they're curved like this. Or you take a ping pong ball and crush it, it looks like that on GMS. I might have a picture in some other thing. But yeah, I think that will be the stem. And they should show you either a HNE or a GMS or both. They want to show you that. Make sense? Pneumocystis. All right.
Can I just change the, I'm just gonna change the pointer to white.
Okay.
Because all the H and E, in the H and E part.
It doesn't show up, right?
it doesn't
Okay,
show
yeah,
up.
yeah. Go for it.
Yeah.
Okay, sounds good. All right, guys, you've got a CT scan and you've got what's in
H and E.
H&E. All right. What do you see on CT? Yeah, you guys should be able to describe this pretty nicely.
Diffuse ground glass, patchy, Cheerio sign.
Yeah, diffuse and patchy are opposite of each other, right? So it's either diffuse or it's patchy.
Sorry, patchy.
Yeah, yeah.
Patchy bilateral.
Patchy bilateral ground glass. Yeah, yeah, yeah.
And then on the periphery on the right side, that
Yes.
may be like a part solid
A nodule.
nodule.
And you're talking about this one here?
Yeah.
Yeah, okay.
Yeah, that's surrounding.
What else? What else?
You mentioned the Cheerio sign.
Cheerio sign. So this, yeah, so this kind of thing, right?
Yeah.
Would it be fair to say that Cheerio sign is like it's like a hole in a nodule? It's like a donut,
Cavitating.
right? It's like cavitating nodules. And would it be fair to say this is not the only one? Here's another one.
Yeah.
So bilateral nodules?
Yeah.
What's the size, do you think? Like is it 2, 3 centimeter, 5, 6? No? How big are these?
Less than.
Less than 1 centimeter? Ah, they're millimeter size. Huh?
Yeah.
Millimeter size bilateral nodules with this kind of donutty sign and glass opacity. I am surprised you don't already have a diagnosis based on that. You don't need the H&E. And actually, it would be unfair to have you guys make the diagnosis of the H&E. It's okay. Should I give you STEM? 45-year-old heavy smoker with incidentally detected CT scan abnormalities while undergoing workup for a shoulder fracture. 45-pack-year current smoker. It's really only one thing that does this exactly. What if I told you that, that this is, if I told you instead of nodules, I said bilateral cysts?
PNCH.
Yes, so I think this is a blind spot you guys have, is that you think of PNCH as the differential of lung and cystic lung disease, but PNCH is not only cyst. It can be nodules. In fact, nodules are the thing that we see more, so we are biased toward that kind of presentation. So PNCH does both nodules and cysts and ground glass opacities. It's a smoker, right? So we'll have bilateral GGO. So think of PNCH when you see a combination of nodules and cysts. You guys again, you're biased to think of LIP when you hear that, but LCH is a classic thing when you get nodules and cysts. They tend to be upper lobe predominant. Smoker is a very big clue. When you're dealing with like these cavitating things, the fact that somebody is a heavy smoker is the thing. They're always millimeter sized nodules bilateral. Multiple bilateral millimeter sized nodule. That should evoke in your brain. You should be thinking, oh, could this be some kind of biliary mets? Could it be some kind of infection? If you are thinking that in the differential, you should be also thinking of PLC.
Yeah.
So what this picture is showing you is these are the Langerhans cells. They look like histiocytes, but they're very irregular nuclei. And they're mixed in with those cells, which you guys should know what those cells are. Anybody? So the cell I'm pointing at now.
Are those eosinophils?
They're eosinophils, yeah. So in Langerhans cell histiocytosis, you get a mix of Langerhans cells and eosinophils. That's the characteristic.
Which are the Langerhans?
Like I'll point to one. So this is the nucleus of a Langerhans cell. That's another nucleus of a Langerhans cell. That's the cytoplasm of that cell. Here's another one with the cytoplasm. So superficially, they look like histiocytes, except they stain differently. They are stained with, you should know that because they might give you that in the stem.
S100.
S100, CD1A, Langerhans. If they give you any of that, they're trying to push you towards that. So remember, they might either give you cysts or give you cysts and nodules. But when they give you the smoking history, that's a
Even
they are
it's not
pushing.
a nodule. I think someone on like GM on the chat said PLCA.
Yeah, good. Good. All right. Okay.
H&E.
H&E. No CT here, it would be too easy for you guys. Like
That's like a world. If I talk about
a whirl of something, right?
a world of Highland.
So, is this?
I don't know what's at the bottom.
Don't know
It's
what-
alveolar space filled with hyaline.
With the mucin, yeah, you're good. Yeah. What's going on there?
Is that the pleura? Is this like an open lung biopsy?
This is an open lung biopsy. This stuff is pleura down here. Okay.
this magnification is of the,
Very low magnification.
that's low magnification
This is very heavy.
of the,
No, not of lung, of the lung.
So is this like pulmonary alveolar proteinosis?
All right, that's a good thought. All right, let me give you STEM, okay? Little bit of a STEM. 72-year-old man, ex-smoker, with 4 years of increasing cough and shortness of breath. Now has restrictive pulmonary function tests and bilateral reticulation on chest CT with lower lobe predominance.
we have fibroblastic foci,
Yes.
IPF, you can see normal lung and bad lung from the chest.
This person
IPF,
is a genius. All right, who's that?
Avantika.
Avantika.
Avantika and
I would
nature.
expect nothing less of Avantika because she's like a.
I think Avantika, nature and Chia, all three of them. Said
Very good, very good. No, they've actually.
Yeah.
Absolutely. So this thing that they mentioned is a fibroblast focus.
Okay.
So that's a word of actually you described it correctly. Hyaline. No, that hyaline material is collagen. The big thing that you. But these elongated skinny cells, those are fibroblasts.
Okay.
So a fibroblast focus is one of the cardinal features of UIP. And the other thing I'm showing you is that at low magnification, there is super abnormal lung on one side, and right next to it is normal lung. That's the patchy fibrosis, patchy or patchy.
And where, can you point me to the pleura?
The pleura is here. It's what covers the lung, the outer covering of the lung. That's the pleura. This is all abnormal fibrotic lung. That's non-fibrotic lung. This is the fibroblast focus. And this thing that is filled with mucin is called honeycomb change. So it's similar to alveolar proteinosis, except the material is not protein, it's mucin. And these are not alveoli, these are dilated like respiratory line spaces. These are abnormal. This is not normal alveoli. Yeah, so again, this is not something you should be able to diagnose from the HNE alone, but they will give you some step. They'll give you a stem, and once they tell you, low lobe predominant and reticulation, that should be you here. And they should give you. I mean, if I were them, I would give you at least one picture of a fibroblast focus, so you could, say this is not NSIP, for example.
Oh,
It's good. For NSIP, you would not have this kind of normal abnormal thing. Everything would be the same. Everything. Mildly facade. Make sense? All right. Ooh, this is very, very difficult. But let's see if we can. What stain?
HNE.
HNE. This is 39-year-old woman with a stroke and now has a kind of pneumonia-like process in the
We have lipid pneumonia.
Foreign body.
Yes, very good. He's got it right. He's got it right.
Okay.
So yes, this is a foreign body. These little squarish things? That is a vegetable particle. And this cell that's trying to eat up this thing is a multinucleated giant cell. It's perceiving this vegetable as foreign in the lung and it's trying to remove it. So this is the classic appearance of when you ingest you aspirate a food into your lung and it causes a foreign body.
Do they actually end up being successful in clearing the vegetable?
They degrade the vegetable and eventually, if you give it like years, they will eventually remove it. But it's very, very resistant. Some vegetable particles are very resistant, which is why even months to years after somebody is aspirated, we still see it in the lung. And there's still evidence of old aspiration. But if you aspirate, let's say, food, like a hamburger, like skeletal muscle particles, they are rapidly degraded and they go.
So eat more.
So protein.
Yeah, less veggies in the diet. Yes.
Eat more meat.
Especially if you're aspirating. Steak.
All right, guys. Ooh, all right. Tough, but a good case to show. Stay.
HNE.
HNE.
That multinucleated giant cell.
Very good, very good. Multinucleated giant cell down here.
Lymphocytic and see a lot of lymphocytes.
They are not lymphocytes, but they are similar. Yes. Let me point out one cell if you tell me what that one is, right above the arrow. But 3 lobes, right? Eosinophils have 2 lobes. This one has 3. This is a neutrophil. So all the cells in that area there, all the way from there till here, they're all neutrophils. Suppurative inflammation. Yes, it would be but there's something you're missing in this
It's a lot of like vacuole-esque substances.
Yes, vacuolar. What are those vacuolar substances?
Foamy macrophage.
I'll point to a few. There's that. There's this. There's this one here. This. Okay,
Could it be fungus?
I'll give you a step, okay?
Yeah.
56-year-old woodworker from Wisconsin
Mhm.
comes down with a fever and has a large right upper lobe consolidation with a air bronchogram in the middle, and suspicious for malignancy. Rule out malignancy, and then a biopsy was performed.
I mean, I don't see anything broad or budding, but area is quite damning for blasto.
Yes, correct. Actually, this thing is a broad base bud. So see that this is the daughter, this is the mother, and then this base is broad. So it's tricky, it's not that easy to see. There's another one here, mother, daughter, and a broad base in between. The other thing is when you get suppurative or pus-like lesions, it points towards blasto. They used to be called bio-granulomas in the old literature because it's granuloma mixed in, and the granulomatous part is this one. So granulomas mixed with pus-like acute inflammations, bio-granuloma, blasto. So blastomycosis. All right. Oh, there I just didn't know it was labeled before. Yeah, so it's those guys. Oh yeah, one of them is in the giant cell actually. This guy. It's tough because you're not sure is that
It's
just
not
a
a
vacuole?
classic,
It's not a
yeah.
classic thing. With a wall. Hopefully they'll give you a more higher
Classic. Yeah.
one organism, easier to see. Yeah. All right, guys, no stem so far.
I see some height.
Very good.
Filamentous fungi.
Very
This is
good.
Mucor.
Okay, you're almost there. You brought it almost to the
So
thing.
filamentous fungi.
Yes. Anything else in the picture besides the fungi? You're almost there.
Trying to see if there's more. This is definitely doesn't seem like Aspergillus. I can't see this.
Is this lung? This thing here? No. What is that?
Anyone, just small.
No, it's hard to see because the whole thing is necrotic. But this thing
It's like a blood vessel.
is like a blood. It is
Invasive
an
pulmonary
yes.
Aspergillus.
It's an invasive pulmonary Aspergillus. That whole thing in the middle is an artery, And the thing is, these things are breaking through the wall of it. See, like here. So you were absolutely right about fungal hyphae. And if there were any septa or acute angle branching, actually there is a branch here.
Yeah,
See
she
that?
recorded right. She said Aspergillus.
Very good, very good. But Mucor is the closest difference. So you're
Yeah.
almost there.
Okay.
And frankly, this is not the best picture to differentiate the two. You should have gotten a GMS that would show you the morphology better. But now you guys have got the idea of yeast versus hyphae, right? And so how helpful is
That's
that?
very helpful.
Yeah. Okay, great. Also stem for that, like I said,
EML.
AML, neutropenia, and all that stuff. Oh no.
This is IPF.
Volleyball.
No.
This is not IPF.
No. What is that?
That's pleura.
Pleura, very good. And alveolated lung, right?
Alveolated
Yeah.
lung. And then you have whorls.
You have words.
Fibroblasts.
But those are, no, you're right about the fibroblasts. There are some fibroblasts
So
here.
the silicosis.
You're getting closer now.
Mhm.
Oh.
Okay, so they do have fibroblasts, but there's something else.
Granulomas.
They are granulomas, which makes them, yes, sarcoidosis.
Sarcoidosis.
Sarcoidosis. Now, this one is a bit odd because I think there's a little necrosis there. So this is not the best picture to show sarcoid. But really, if someone wanted to show sarcoidosis, they would show you a closer picture where you would see those are histiocytes.
Okay.
Yeah.
From the chat we had Anna said granuloma.
Yes.
Rachel and Avantika said granuloma.
That-
And
that's
we
it.
had a question about organizing pneumonia, and I can never tell. Like we can't are not good at telling what
Yeah.
non-body is.
Well, the key is the cell in that whirly thing, is that cell a fibroblast or is it a histiocyte? That is really the key. So
So
fibroblasts
it's-
are very skinny, the nuclei are very elongated.
Okay.
And the problem is in granulomas, the histiocytes also get a bit skinny. So it's not an easy to extract.
Okay.
Yeah, they tend to have a little more pink cytoplasm, the granulomas.
Okay.
If you see a multinucleated giant cell, that will be a clue towards granuloma and will take away the. But
The
if they're,
non-body.
yes, so for example, in this picture, the things at the periphery are actually fibroblasts. The things in the center are granulomas.
Oh.
It's granulomas surrounded by fibroblasts.
Okay.
Very, very tricky at this max. So this is not a fair picture at all. Not fair. All right, guys, you should absolutely nail this.
This is stain.
Yes, which makes it.
Histone.
Fungus.
Come on. What's that? Cryptococcus, sorry, Cryptococcus. You were so close.
That's exactly what's gonna happen on board. I'll be close and that's it.
Everybody okay with this? So the mucocarbon stain looks different. It has a kind of a yellowish background, and the stain is actually pink or
5 people on the chat said
very good. Yeah. So this, if they give you this, you don't even need a set. This is absolutely diagnostic. I think the money. Cryptococcus. All right. Okay, guys, you should get this now. Without stem.
dense consolidation.
Dense consolidation, square micrograms, unilateral. Right, and there's some tree, but maybe on the left side.
Is that broad-based budding with the two things on the right?
So it is.
Blasto.
You got it.
Yes.
You got it. So see, there's a mother and a daughter. I don't know which one. They're both the same size. So either one could be the mother. And who knows?
Ask how you do.
I don't know. I'm guessing. Let's call them sisters or whatever. I know. So, yeah. No. So there's two parts, and where they connect is broad. That's the idea. Yeah. Also, blasto. One thing is it contains this purple thing inside it. You see,
Yeah.
that nuclear material is actually only seen in blasto and cocci. The other two don't have it. These two and crypto don't. So broad-based bud. If you can see a broad-based bud, you're done, and you don't need to think of anything else. And usually, blasto, classic blasto at least, gives you these, very consolidative opacities, which are characteristic. All right, great, guys. Very good. Huh, not fair.
So multinuclear.
Multinuclear giant cell.
Something inside it.
That's
It's
it.
eating up something.
Do you know what that is? They might give you this, and it's actually not at all accurate, but
I don't know.
and in this case, actually, they might even have a
Asteroid body.
might have a fungus inside it. Yeah, but if there's an old-fashioned examiner who's making this thing, they might give you an asteroid body as a clue to sarcoidosis.
Okay.
In reality, that's not true at all. So asteroid bodies are not specific for sarcoidosis. But if you see that on your boards, be thinking of that. Be thinking that this little spidery thing is a clue to sarcoid. And if the other things in the stem fit, then you should be going to it.
So Rachel,
Where is the multinucleated giant cell?
So in this, see what I'm circling? This whole thing is the multinucleated giant cell.
So it's all one cell.
All cell, and 1, 2, 3, 4, 5, 6, 7, 8, 9, 10 nuclei all belong to the same cell.
Okay.
The only thing that's not a nucleus is the asteroid body here. And the thing there, which I suspect that's a fungus, but I'm not sure. And then the giant cell is also kind of phagocytosing a lymphocyte. So that's a lymphocyte.
So what other conditions would you see in asteroid body?
Any foreign body giant cell reaction, any infection, it's like completely non-specific.
Okay.
Non-specific. Yeah. All right. Huh?
So etany stain.
Yes.
Round spherules
Yes.
with tiny things inside it.
Very good.
Cocci.
Oh, amazing, amazing. Yes, yes. Right? So the things on the outside, those are called spherules. The big balloon is called a spherule, and the little balloons inside it are called endospores. And that combination of spherule and endospore only happens in cocci. There's no budding or anything. It's just a thing filled with. In the boards, they might not have a picture as good as this. They might give you ruptured ones, which are like, you'll see that balloon is broken. And there's nothing inside it. So that's also okay. But remember to look for stem, the appropriate area.
Yeah.
And lung nodule or immunosuppressed patient, any of those things. Make sense? Ooh. All right.
So bilateral ground glass on CT.
Bilateral ground glass on CT. Actually, there's more than just that.
There's nodules. That's
On the CT.
yeah.
Okay. Hair trapping.
Mosaicism.
Mosaicism.
Nice.
So you don't even need the right?
It's HP.
Yes. And what would you expect to see in HP on the
Lymphocytic infiltration.
Are there lymphocytes in the? Yes, there are lymphocytes. So there in the bronchioles, there are, around the airway, there are lymphocytes. What else do you expect to see? In each? Granulomas or giant cells. Are there any? See that little
Black
circle?
arrow.
See the circle?
Oh, that's
Those are giant cells. There's one in the at the circle and one right to the right of the circle. So giant cells, you expect to see that in HP. You also expect to see some interstitial thickening, which you see here. So the black arrows are actually showing you lymphocytes in the interstitial. And this one down here shows you an airway bronchiole with the same thing. Lymphocytes, one giant cell here. Perfect HV. Actually, frankly, you don't need the HV with that kind of CT.
That is sick.
Used to be called head cheese, and now do you know what it's called in the new?
Neutral density.
Yeah, 3 densities. That's just so that somebody can get a paper, where they can. Just skeptical. The cynic in me speaking. Okay, what is this? Guys, before anybody says anything, those are red blood cells. So ignore that.
So you see, I see giant, since I don't know if there's necrosis.
Yes.
There's definitely a granuloma.
Very good.
Maybe
Which
some
one?
necrosis. So the one in the center.
This thing is a
And the
granuloma.
pink material in the center,
This?
that is that necrosis?
No, that's a giant cell.
That's a giant cell.
That's a giant cell inside the granuloma.
Okay, so it's granulomatous. I mean, it could be so many things. Non-necrotizing granuloma.
Yes, what's top of your list?
Sarcoidosis.
Yes, so that's what. So look for a stem like that. Look for bilateral nodules, bilateral symmetric, look for hyalomediastinopathy, all the million other things they could put in the stem for sarcoidosis. So if you can recognize a granuloma, you're way ahead of the game, because it's difficult to know that. But this is what a granuloma looks like. So in this picture, this thing is a granuloma. The pink thing here is fibrosis. That thing is a granuloma there. This is the airspace, which is completely uninvolved. It's the interstitial where the granulomas are. That's another granuloma. This is a granuloma. This is a granuloma. And the pink things that stand out are actually giant cells. So there's a giant cell there. There's a giant cell here.
Necrosis is present.
It's again difficult. You have to be. It's pink debris without any stuff in it. There's no nutrient. It's just debris.
Just pink.
Pink. Yeah. It's like the tissue is falling apart. It should look.
But not like fibrosis.
Not like fibrosis pink. So telling what is fibrosis and what's necrosis needs some, you need some.
Good point.
Yeah.
Hopefully they won't answer.
Just imagine pathology is a thing. We spend our lives telling what pink means what, or what purple means what. So yeah, same deal with amyloid versus fibrosis. How do we tell? It's just subtle things. How do you tell whether somebody's from India or Pakistan or Nepal? They're subtle things, right? How do you tell if an Indian is North Indian or South Indian? It's like very subtle things, which it's difficult to explain because they are very subtle. Okay. Very good. Yeah. So you're down to fungus already, right?
Yeah.
Aspergillus, circles and circles. Aspergillus.
So what does it make it? Coccidioides, but on a GMS. And you see that? So it's the same thing. Empty spherules.
All right, I'm funny. We're in a parking lot, so you're gonna hold my hand, okay?
Is somebody unmuted? Okay. So yeah, we've discussed this already, right? Very good.
Hey, I think your boots are on backwards.
Hey, Chris. You're
Should we fix those really quick? No, fix them
Hey,
inside.
Chris.
The good thing he's not saying anything inappropriate, which is
Yeah.
It's good.
like this pathologist sucks. Chris. What's that?
That's what
Lots of hyphae. So you're down to 2 things.
it's not branched as such.
Not branched.
Looks like
It's so hard to tell if it's branching.
Yeah, it's hard to tell if it's branching around. You really have to follow those things. Okay, what if I tell you this is a patient with cystic fibrosis with a cavitary lesion with the what's that called? Monod sign or something? I forgot what that thing is.
Aspergillus.
It's
Aspergilloma.
Aspergilloma. Yeah. Right. So you tell the patient and the thing falls over. So this is Aspergillus when it's tightly packed together, like in a fungus box. That's what it looks like. It's the same thing, but they're very compacted together. Tightly.
Hard to see branching or separating.
Yeah.
It is. That's completely fair.
So
Yeah.
because I was going with what you said earlier.
and it is like pauciseptate or aseptate.
Yes.
Mucor.
No, I totally understand, but I'll give you the counter. It's like, look at here where the walls are completely parallel and there is the septa there. So that, it's tough. I'll grant you that. It's difficult. All right, so this is a, fungus ball, mycetoma, aspergilloma, whatever you want.
I definitely see high phase.
Yes.
But are they also spores?
But don't transfers cut.
This is
No, this is also most likely.
So how do we tell about Aspergillus and Mucor? Is it just through the stem?
Yes, if they want Mucor, they'll probably give you diabetes or something like that, but if this, and this is very unfair if they don't give you a stem to help you, but if it's morphology, then you have to use these things. Septa, shape of the organism, parallel walls, narrow angle
branching is also like right angles.
narrow angle for Aspergillus and broader for Mucor. Mucor looks very irregular. If you get parallel sides like this, it's Aspergillus. Yes. Mucor doesn't give you this beautiful morphology. Yeah. Oh, what is that? If they give you that, that's also diagnosed. Do you know what that is? Those are called fruiting bodies. Fruiting bodies only form in Aspergillus. Like it's like a thing, and these spores coming out of it. Those spores are the infectious forms of Aspergillus. So those fruiting bodies only form in Aspergillus and do not form in any other. So that if they show you a thing like that, that's diagnosed. Fruiting bodies. All right. That forms wherever Aspergillus is exposed to air, like in a cavity or in a bronchopleural fistula. There's some connection to air, fruiting bodies form. All right, what's going on here? Of a. All right. So you have some context. That's what the low mag of the biopsy looks like. Yes. Yes. It's classic. So this is classic that you have somebody who lives in Arizona goes to the doc and says, "Oh, do I have cancer?" And they put a thing in this. It's a granuloma with Coccidioidomycosis. Yeah.
Multinucleated giant cells.
Very good. No, what are these? Neutrophils. You correct. 3 to 5 lobes.
Neutrophils.
3 to 5 lobes in neutrophils and 2 lobes in a eosinophil.
I see circles within a circle.
Yes.
To the left of the multinucleated giant cell. So cocci.
You're close. Yes. So that is the differential really. Versus what's the other crypto? Crypto is too small. It wouldn't be in this list. If you're thinking cocci, then crypto shouldn't be in your name. Like blasto.
Okay.
So that actually is also a broad-based bud.
Broad-based.
Yeah, there. And remember, neutrophils in association with granuloma is another bio-granuloma. So this is blasto. Again, should have a stem, but bio-granuloma. All right. Here's it's all labeled, so you'll see the difference. Broad-based budding. See the broad base there. The big thing with the endospores inside it, here's an intact endospore. Here's a crypto with the halo. And there's histo small uniform things with narrow base budding. So that I'm pointing now to a narrow base bud. Make sense? Okay, this is fair. 48-year-old woman with scleroderma. Okay, fair.
Lymphocytic infiltration, giant cells.
No giant cells, but lymphocytic infiltration, yes.
And what are those? Oh, are those surface?
Here,
Yeah.
that's a blood vessel with endothelial cells. There's blood in the middle of it. See that? Those are blood vessels. These, yeah. So no giant
What
cells.
about,
but
yeah, what about that one? That is
yeah.
is
blood
that giant cells?
blood. But you're right about the lymphocytes. A few LIP is just teeming with lymphocytes. Like it should be blue.
Okay.
Yeah.
NSIP?
NSIP. Yeah.
About the convention.
Yes, yes. Yeah.
NIP is, I think, seen in Sjogren's, not scleroderma.
Correct. So if they want you to give LIP, they really should give you Sjogren's in the history. Otherwise, it's basically vanishingly rare to ever get a real LIP. Yeah. So and if they give you any other connective tissue disease in the history and give you uniform fibrosis like this, it should be they're looking for NSI.
But I don't see five.
You shouldn't get fibroblastosis.
Right.
No fibroblastosis, no honeycombing, no patchy fibrosis.
Just all lymphocytes and thickening.
Yeah. The thickening is lymphocytes plus fibrosis. That's what it's called. That's the pink. So the pink in here is all fibrosis. The blue dots are all lymphocytes.
So there's no separation between normal and abnormal.
There's no separation between normal and abnormal. They really should give you that if they're trying to show you UIP. And if they don't, if there's no separation, then they're pushing you towards NSI. And then the age will be different. They'll give you an older patient for UIP, a younger one with NSI. Hopefully they'll give you some CTDs. Make sense? All right. Not the music.
No, sorry. GMS.
Yes, yes.
With ground glass bilaterally. One of these bugs.
I see what you mean, like something like that.
Imaging wants me to say BJP.
Yes, yes, it is. It is. It is. So this is like the crescent shape I was talking about before on the GMS. And also see that frothy thing that I showed you on HLE. When you stain it, turns into this. Yeah. The froth with dark thing.
This was the ball crushed.
Correct. The crushed
Yeah,
ping pong
yes,
ball.
crushed ping pong.
Something like that. To me it looks like a bowl, but some people call it crushed ping pong ball appearance. These instead of all round things, there are these odd shapes, like a saucer or a crescent.
So is that because of the preparation of the slide, or is it because of?
It's because of the organism itself, organism shape itself. Yeah. But the H&E doesn't show you the actual cyst. It just shows you these dots, which are called trophozoites. So you are seeing different things on the H&E and the GMS. Yeah. So if the stem is immunocompromised and there's ground glass opacities and a GMS, you're almost certain that that's PJP. It should be. All right. Yes. Hyphae. There's a capillary mass. Aspergillus. Yeah, this is chronic capillary Aspergillus. Makes sense, right? It's a semi-invasive disease. All right. Very good, guys. Ooh, all right.
HNE stain.
HNE stain. I'll give you, let's see, without the stem, then I'll give you one thing in the stem and you'll get.
Lot of lymphocytes.
Very good.
That.
Yes.
Lymphocytes.
Where? Is it in the
Interstitial.
interstitial?
And then the
This is LIP.
This is LIP.
This is LIP. One thing that, they may not know this, so I don't know if you get it, but in LIP, the air spaces are filled with this pink stuff. If you have a good exam setter, they'll give you that in the.
What
in the
does
picture.
it stop?
So it's just proteination, but it's very common in LIP for some
Okay.
to get that. But yeah,
But you
remember,
wouldn't see that in the side.
you wouldn't see that in NSI. And LIP should be very blue because it should be almost like a lymphoma, That's how many lymphocytes should be in there. Yeah, and Sjogren's in the stem. All right, so let's, how much time do we have? 9 minutes. Let's go back to the beginning. Let's see if we can do a few more things. All right. Now let's start with, let's start with this one. Yeah, so you're on the right track. Now I tell you, this is a 79-year-old lung transplant recipient.
Rejection.
Which kind?
Cell.
Cellular rejection, because those are cells, right? So once you see cells around blood vessels, they're going to be lymphocytes, and that is the hallmark of acute cellular rejection. So yeah, that's all you pretty much need to
Also,
know.
that's the main thing we find in pathology, right?
Correct,
Rather
yeah.
than antibody-mediated rejection, signs that you can tell.
No, there, this has been controversial for decades, what you see on histology, and there's no consistency.
Okay.
It's really a,
Do you ask what about HP?
yes, so if it were not a transplant recipient, it would be fair to think about HP.
Okay.
Then you would look for, it would be odd in HP to have just normal lung right there.
Mhm.
Everything is slightly abnormal in HP. You've got the giant cells and the granulomas and the bronchiolitis. Just to have one focus and only around the blood vessel, it would be odd for HP. Okay. But good to think of it. It's good to think of HP when you see lymphocytes.
Oh, she said for the last one, HP versus LIP.
Oh yes. So for again, the same thing. The stem of Sjogren's,
Okay.
the CT with the air trapping and all that,
Mhm.
and then the absence of granulomas and giant cells.
And the pink material. So
The pink material, yes. Yeah. So yeah, they will not give you a case where they're trying to fool you. They'll give you, in the stem, things that point you to the right way. But they're right to think that both HP and LIP have lymphocytes in the interstitial. That's correct. So does NSIP. So it's not as easy as saying, hey, here's a lymphocyte in the interstitial, here's what it is. It's not that easy. There's a differential for that. Yeah. Okay. Ooh, no, this is hard. No, forget this.
CK56.
Yes, marker of what? Okay, I'll give you a stem.
Mesothelioma.
Yes, very good. Yeah, so the stem will say 83-year-old with recurrent unilateral pleural effusion that has to be tapped repeatedly and keeps filling up. Then has multiple nodules along the pleura, and then you see the one they might give you in the stem is called calretinin. That's the marker of mesothelioma. Calretinin and then CK56. So if they give that, that's mesothelioma. Ooh, tough, but I think fair. Tough but fair. You guys know what this is? See those things there?
This is endometrium.
Good thought. No, but it's not. What am I pointing at here?
Cilia.
Cilia, right? You wouldn't get that in endometriosis, right?
That's the brown.
Yeah, it's bronchial epithelium, right? So you can kind of ignore that and now look at the other stuff in this.
Goblet cells.
There aren't any here, I don't think. I don't think there's any goblets.
Subepithelial fibrosis.
Yeah, so that subepithelial fibrosis, look at it again. I think what else could that be? Remember we were having the discussion about pink versus pink versus pink.
Amyloid?
Amyloid. So that's the kind, it's like a more homogeneous, it's very difficult to tell. But what they'll do if they want to give you this is they'll tell you, 80-year-old with bilateral pleural effusions, with cardiomyopathy, and they'll give you a Congo red stain next to it. So on Congo red, this thing turns like a sand color. And if you birefringe it, they'll show you apple green birefringence. So that's the key thing you're looking for, apple green birefringence. And this kind of very pink material that looks like fibrosis, but is a little more homogeneous.
Congo red is also like mucicarmine in that if you just see the stain, it's diagnostic of a particular thing, right?
That's true. Yes, that's correct. If it turns green, then it's diagnosed.
Can you point towards where the sub?
So this is the epithelium, right? This part, so this from here till here is all subepithelial. But this is the amyloid, this. See, this is amyloid. It's acellular eosinophilic material. I don't have any fibrosis to compare with here, but if you had both, I could show you how it's different. It's very subtle difference from. And because it's difficult, that's why you need a stain. That's why you need the Congo to prove that it's amyloid.
Dr. Mukhopadhyay, how about the small particles, the plaque particles?
Those are dust. See, those are
Dust.
macrophages filled with dust. Yeah, just environmental dust.
Do those also clear?
Do those also do what?
Clear? With macrophages, etc.
So macrophages take a long time to clear any kind of particulate material from the lung. So the classic example is smoking, right? So in smoking, you inhale all that dust that gives you these pigmented macrophages. In the literature, they've shown that it can take up to 32 years to clear that after you stop smoking. So yeah, it clears, but it takes a long, sometimes years. Good question. It takes it from, so those macrophages take it into the lymphatics, then it goes to the lymph nodes, and then it accumulates there, and the patient's lymph nodes start looking black because all that debris is good. 69-year-old smoker with a 3.2 centimeter speculated lung mass. This might be a fair question for your with that step. SUV, 9.8, slowly enlarging. What's that? Like squamous? No. So I'll give you like an easy way. See these little spaces? See those spaces? Each one is a gland. So that space surrounded by, those are tumor cells. So a space surrounded by tumor cells is a gland. By definition, it's adenomas. Squamous cell carcinomas don't have that space in them. All right. Adeno. 79-year-old man with COPD comes in with dizziness and was found to have a brain met. So they imaged the chest and found a definitely cancer. Also had a yes, very good. Yes. So in the stem, it would be fair to give you SIADH or give you hyponatremia, tell you a big mediastinal or hilar mass, tell you the patient is a big time smoker. All those would be clues towards small cell. But the key here is all nucleus, virtually no cytoplasm. Very blue looking, right? And if they give you mitotic figures like this, that might be a clue, like that one up there. Yeah, so small cell, very purple or blue or whatever looking. And with the stem. Okay. Lung transplant is again. A little unfair, but you're close. No. Boss. Yeah. So this is bronchiolitis. What's happening here is this thing used to be a bronchiole. You see the smooth muscle here? Smooth muscle bundles on the periphery. So this structure used to be an airway bronchiole with a lumen in the middle. That lumen is it's obliterated by fibrosis. So this is what happens when you get boss. So you get the decreasing FEV1, patient gets more and more short of breath, irreversible. This then needs retransplant. Right? This is what we're seeing on PATH when that happens. It's obliteration of a bronchiolar lumen. All right, last one, and we stop. Yeah, one more. Yeah. Last one.
Yeah.
Ooh, beautiful. Tell me why.
It's like everything is just, the air spaces are just filled with a highline, like.
Yes,
material.
pink material. Yeah, pink granular looking material.
Yeah.
Yeah, and they sometimes have these globs which are very useful. These pink globs, those are surfactant globs. Different than these. What are those? That's it. Okay, because he got it so easily, I'll end with this one. Okay. 65-year-old smoker with a cavitary
SCC.
This is
Keratinizing.
yeah, correct. So you see the difference between this?
Huh?
Keratinizing products. These swirly things in the middle, that's keratin. And these are the tumor cells. So these are tumor cells. The swirly thing is keratin. Anything that makes keratin and is malignant is a squamous cell carcinoma.
Which is
That's
the keratin again?
These swirly thing, these are keratin pearls. So keep that in your mind, okay? Keep it in your mind.
Adeno was.
And look at this now. This is adeno. This is small cell. This is squamous. All right. Okay, guys, you've been great. Thank you.
Thank you so much. This is like the most activity we had in our chat.
Oh, really?
Yeah.
Oh, wow, that's great.
Thank you so much for doing this. All the 30 years are very, very pleasure.
Happy to do it. Happy to do it.
Oh, yeah.
Okay, but let's post this, okay? I'll give you a little Dropbox thing and you can
Okay.
tag it in there.
That sounds good.